I'm super delighted to introduce Kara Margolis. Kara is a professor in the departments of molecular pathobiology, cell biology, and pediatrics at NYU. She is a pediatric gastroenterologist and the director of the NYU Pain Research Center. The Margolis Lab studies the role that the gastrointestinal tract plays in anxiety and depression, abdominal pain-related disorders, and gut-brain interaction, as well as neurodevelopmental disorders. Her research focuses on the discovering of the ways in which we can alter gut signaling to treat disorders of the brain and the gastrointestinal tract. For example, she has uncovered roles for nutrients and the microbiome in depression and anxiety and neurodevelopmental disorders, including autism spectrum disorder. And I'm really so happy for her to be here. I've known of Kara for a very, very long time, really years ago, and we only met in person a few years ago. And when I saw her at the ANMS meeting in Minneapolis like a few months ago, it was clear she was a magnet, and I am really delighted to have her here. So please help me in welcoming Kara.
Thank you, Julia, for that beautiful introduction and for the invitation to come here. I'm really honored to be here in this audience with the scientists, the speakers, and with all of you. So I am going to be talking today about afferent serotonergic signaling in gut-brain health. I'm first going to talk a little bit about the clinical implications, and then talk about how we've segued between mouse and human studies to develop a novel therapeutic concept. So I'm going to start first by showing you some videos of people who have a heck of a lot more followers than me on social media. So maybe they know more than I do about gut-brain health.
So to test if your bad breath comes from the gut, I want you to grab a cup of water, fill it with water, and then you're going to spit inside. But if your cup of water looks like this and your spit turns to strands, you're going to get rid of it with the mother, which is apple cider vinegar.
This will flush all the toxins out of your body. You're gonna have way too much energy. Your skin is gonna be way too clear, and you're gonna be too productive.
Okay, I don't know about you, but I am sold if this really works. So, I think what this shows is we know that there's a gut health craze out there, but with that comes
to test if you're bad.
Comes a lot of misinformation. And what I've really become kind of addicted to is this gut talk. So TikTok that's focused on the gut. There's over 70,000 posts and over 7 billion views. So if this gives you any idea of the impact that we can have on gut health and what truth is, this is a good indicator. So why is the gut so important, and why is gut health all the rage right now? Well, we know that gut health has been linked to every different type of health on social media and also in research. And we know that a key area where there's a connection is between the gut and the brain. And certainly when people think of the brain on social media, people think about mood disorders. And there's a lot on how we might manipulate the gut to fix mood disorders like anxiety and depression. And why is this important? Because we know that there's a mental health crisis. This is a study from the US Census Bureau from 2023, and what it shows that almost a third of all adults have symptoms consistent with an anxiety or depression-like disorder. And even more concerning is that the largest population, almost half, are in young adults, so the youngest population surveyed here. So how do we put this all together? Well, we know that there is a gut-brain health crisis in what Casey talked about a little bit in disorders of gut-brain interaction. We know they impact over 30% of the international population. And for those of you who aren't familiar with disorders of gut-brain interaction, which I'm also going to be referring to as DGBIs, there are 3 major features. There's abnormalities in gut-brain communication, dysmotility, so constipation or diarrhea, and abdominal pain. And so how are the brain and gut linked here? What we know is that disorders of gut-brain interaction are highly comorbid with mood disorders. So over 50% of patients with a DGBI also have a psychiatric condition. Overwhelmingly, that's anxiety, but depression is also fairly common. And in this really nice systematic review published 2 years ago, what you see is that mood is the major risk factor for abdominal pain-related DGBIs. In fact, in encompassing adult and pediatric studies, the only two factors linked to both the presence and persistence of a DGBI are stress and psychological disorders. So as Julia mentioned, I'm a pediatric gastroenterologist, and so I thought that I'd show you the importance of this concept just through a couple of patient examples, or two patients that I've seen over the last couple of years. The first one was an 18-year-old with severe intractable constipation. So in contrast to Casey saying it, not everybody stools all the time. This patient was stooling once every 2 weeks. She had significant abdominal pain. She was resistant to multiple medications and had a huge workup, blood and stool test, endoscopy and colonoscopy, anorectal manometry, which looks for rectal sensitivity. And her past medical history was significant for severe anxiety, which she was simply treating with over-the-counter supplements. Her exam was pretty normal. She was a little thin. She had nervous tics. She was bloated because she was full of stool. So we diagnosed her with the DGBI, constipation predominant irritable bowel syndrome, or IBS-C. But we also had to consider her diagnosis of anxiety because we know that anxiety drives a sympathetic overdrive to the gut that can cause it to slow down. So we treated her with a guanylate cyclase agonist, Linzess, for her IBS, but we also prescribed her cognitive behavioral therapy to treat her anxiety. And 6 months after treatment initiation, her GI issues were resolved on an as-needed stool softener. So this is an example of treating constipation by treating the gut and the brain simultaneously. Patient 2 is a 16-year-old male, so he had 2 years of diarrhea and gastrointestinal pain. He was having it about 4 to 6 times a day. He had such significant urgency that he could barely leave the house. He had a much more recent onset of depression for about 3 months. And he also, like the last patient, had an extensive workup which really showed nothing significant. Again, his physical was also pretty benign. He was thin. His abdomen was soft with diffuse pain to palpation, but we see that often in patients with DGBIs. So his diagnosis was the DGBI, diarrhea predominant IBS, or IBS-D, and also depression. But because his depression was of a much more recent onset, we decided to focus on treating the DGBI, which we did with a partial opioid agonist antagonist. And literally 1 month later, his IBS-D was under full control, he was in school full time, and his depression was resolved. So this is an example of treating the gut to also treat the brain. So for the clinicians in the audience, we know that when these patients come in, they're really complex. I think I simplified these patients a little bit just to demonstrate the concept of what we see. Because understanding mood and gut abnormalities in general is challenging. We know that there's a continuous 24/7 bidirectional communication between the brain and the gut. So we know that when patients come in with these comorbid conditions, it's really hard to figure out what came first, so what to treat, or even more so, how to treat both simultaneously. And it's our hope that by ciphering out these connections between mental health and DGBIs, which as I showed you is a maelstrom or a tornado at this point, that we might both enhance understanding and it'll lead to targeted effective therapies. So this is an oldie but goodie, talking about some of the factors that have been studied in relation to the gut-brain axis. And as you've seen already from Christoph and Casey's talks, many of these have been addressed already, including the immune system and bacterial molecules. I'm going to be focusing on peripheral serotonin today, not only because it's a major focus of my lab, but because it makes sense that serotonin is a link in the gut-brain axis. We know that serotonin's present in the brain and the gut, but what a lot of people don't know is that the vast majority, about 95% of the body's serotonin, is located in the gut. However, that 3% is critical. It's important for central nervous system development, mood, and cognition. as well as enteric nervous system development, but also GI motility and abdominal pain. So you can see here that serotonin is linked to all these symptoms I talked about. So therefore, when serotonergic signaling is abnormal, all these mood and DGBI symptoms can appear: anxiety and depression, dysmotility, and abdominal pain. So how do these concepts about serotonergic signaling apply to patients? What we know is that current treatments for mood disorders and DGBIs are highly limited. The selective serotonin reuptake inhibitors, or SSRIs, are a first-line treatment for patients with anxiety and depression, and also patients with a DGBI and comorbid mood disorders. I've listed some of the ones on your right over there. There are many, like Zoloft, Prozac, Lexapro. And so even though there are a wide variety, their major mechanism of action is the same. What they do is that they increase serotonin availability by blocking the serotonin reuptake transporter, or SERT. So this is an example of what goes on in a nervous system. You can see a pre- and postsynaptic neuron. You see that serotonin, those little blue balls, are released from the presynaptic neuron. They then go on, once in the gut lumen, to bind to a variety of different serotonin receptors. However, in order to avoid a desensitization or an overactivation, serotonin then needs to be broken down. And so in order for that to happen, it needs to be taken back up into the cell. So the SERT, or the serotonin transporter, is that pump that pumps serotonin back into the neuron, leading to its inactivation. So what SSRIs do is they block SERT. So by blocking that inactivation mechanism, it leads to increase in serotonergic bioavailability. So SERT is present not only in the brain, but also in the gut. And SSRIs act systemically, meaning that they antagonize SERT in the brain and the gut, leading to increased serotonergic signaling in both areas. And while these are designed to treat DGBIs and mood disorders, what our research over the last couple of years has shown is that the systemic absorption may actually be causative, both developmentally as well as in adulthood. And I'm first going to review some of the developmental studies. So the first thing we did was a population scale assessment looking at over 1 million pregnancies in Denmark. And we looked at 2 groups of pregnant women. In dark gray, you can see those pregnant women who were depressed, and in light gray, those who were depressed but took an SSRI during pregnancy. And we followed them at 1 year and through 15 years of age. And what you can see is that irrespective of the presence of maternal depression, maternal SSRI exposure led to an increased risk of a DGBI. And this was really driven by functional constipation, and that's an important thing to remember. So then we went back to the lab because we know that people are complicated and there's a lot of confounding factors. So we did a relatively simple set of experiments where we gave mice the SSRI fluoxetine, or a vehicle control, through key developmental periods, so during pregnancy and breastfeeding. We then stopped the SSRI upon weaning to rule out acute drug effects, and then we evaluated the mice in young adulthood. And we were looking for differences in gastrointestinal motility and enteric nervous system development, and we found abnormalities in both. The mice were constipated and had abnormalities in neuronal subsets in the enteric nervous system that were localized to effects like GI sensation and also constipation. So there had already been a variety of both human and mouse studies linking maternal SSRI exposure to anxiety, depression, and cognitive phenotypes. We reconfirmed those studies. Then we joined up with the group that had conducted all those studies and were funded by a study that we call Get Gas. It asked the question, how does maternal depression plus or minus SSRI exposure impact development of DGBIs and mood disorders? It's the first prospective birth cohort study to examine such a question. We're looking at pregnant women without depression or with depression plus or minus SSRI use, and looking at maternal microbiota transfer as a potential mechanism by which these kids develop these phenotypes. So for those of you interested in the background of the study, again, we have those 3 cohorts of women. This is part of another, it's partnered with another study where we have people looking at the brain. They've done extensive investigations monthly during trimester-wise during pregnancy, and then monthly in the first 2 years of the baby's life. We're looking at Bristol stool scales. We're looking at Rome criteria to screen for disorders of gut-brain interaction, but also depression, anxiety, sleep, and nutrition, as well as collecting blood and stool. At birth, we immediately have samples from the baby, including placenta, as well as stool and blood from the mom. And then at 2 to 4 weeks, we start our routine screening for disorders of gut-brain interaction. We're collecting stool and taking careful measures of nutrition and medical history. And the parent group is doing a multimodal MRI and EEG every 3 months in the first year of life, every 6 months in the second. We're continuing to monitor for those DGBIs and stool microbiome. And at 12 and 24 months, we're assessing for social, emotional, and cognitive development. So the first data published out of this actually correlates with what I showed you before. We looked at functional constipation, and we looked at it over a 2-year period. And what you can see is that, again, mothers who had depression had the same risk of having a child diagnosed with functional constipation as moms without depression. However, those moms that took an SSRI during pregnancy had an increased risk, suggesting that gestational SSRI exposure poses a significant and specific risk for development of the DGBI functional constipation. I want to emphasize here, and I'll emphasize again, that this is not a call for pregnant women not to use SSRIs, because what I'll show you at the end is that we now have data under review which shows that maternal depression, when you take SSRIs out, lead to a different set of DGBIs. So what I'm simply saying here is that interventions with less side effects are needed. So what I've shown you so far, to summarize, is that we first did a population-based study to confirm this association between SSRI exposure and the development of DGBIs and mood disorders. We then did preclinical studies to confirm that it was indeed the SSRIs that were linked to DGBI and mood symptomatology. We're now conducting a prospective birth cohort study to determine whether maternal microbiome transfer is either a biomarker or a mechanism in humans. And now I'm going to talk about how we've gone back to the lab to determine a solution and to work on the drug itself. So we know that SSRIs have major limitations, so we asked why. So first, I wanted to just review what the key limitations are. I've talked a lot about the effects of in utero exposure and the link to mood disorders and DGBI development. They're also highly ineffective, causing relief in less than 50%, placing less than a third of patients into remission. And both GI pain and anxiety, so side effects that SSRIs are actually prescribed to prevent, may actually be adverse effects of them. So we asked the question why, and it goes back to this concept that SERT is present in the brain and the gut, and that the systemic absorption of SSRIs leads to an antagonism in both compartments and an increase in serotonergic bioavailability. So we asked the question, everybody's been focusing on the brain. So we said, do the off-target effects of systemic SSRIs cause adverse effects in mood and abdominal pain? But instead of focusing on the brain, we're focusing on the gut, because we really don't know where the off versus on-target effects of SSRIs are. So we asked the question, where does SERT blockade exert its antidepressive and anxiolytic effects versus its negative effects on GI and abdominal pain and gastrointestinal motility? And we focused on the function of SERT from the GI tract. And we did this in development and young adulthood. But you can't, when you're considering SERT and you're considering serotonin, you can't look at the gut as one whole organ or a single entity, because intestinal serotonin is synthesized in 2 different depots. It's not only synthesized in the enteric nervous system, but actually the majority is synthesized in the gut epithelium. SERT is present in both regions, and we and now others have shown that when you differentially modulate serotonin in the gut epithelium versus the enteric nervous system, that there's very different outcomes in terms of gut inflammation, motility, epithelial growth, and enteric nervous system development. Today, I'm going to be focusing on the gut epithelium findings that we have, because that is where the majority of gut serotonin is located. So we asked the question, does selective ablation of SERT from the gut epithelium induce the beneficial effects of SSRIs, anti-anxiety and antidepressive, without inducing the detrimental effects? And so I'm going to be talking about 2 mouse models today, but what I want to say is that we've used a lot of different models as well as surgical and pharmacological approaches, which have verified this concept in the publication below. And so what we did here, or what I'm going to talk about, is we created these 2 mouse models. The first one is where SIRT was knocked out selectively out of the gastrointestinal epithelium throughout development and life. So this would be equivalent to a maternal SSRI exposure and then a child being exposed to an SSRI, again, targeted to the gut epithelium throughout life. Our second model was a tamoxifen-induced model where you can ablate SIRT in the gut epithelium in a time-specific manner, and we did this in young adulthood. So this would be equivalent to a young adult taking an SSRI targeted to the gut epithelium in young adulthood. And the first question we asked is, does SIRT blockade targeted to the intestinal epithelium promote anti-anxiety and antidepressive behaviors? So we did a battery of anxiety tests. I'm just going to show you 2 that we did here. The first one is the open field test, and I'm going to show you here what you'll see is the mouse on your left sort of sits like a deer in headlights. That has more anxiety, while the mouse on the right has a lot of measures of exploration. He moves around, he does a lot of head rearing, and that mouse has less anxiety. So this is one of the tests we did. The second was the novelty suppressed feeding test, where you fast mice overnight so they're hungry, and you can see that there's a pellet of food in the middle of that bin, which we place them in the next day. So they're hungry, they should want to eat that pellet. However, you can see that pellet's on a white circle. White causes anxiety in mice. So the longer it takes that mouse to get over that white circle and eat that pellet, the more anxious they are. And what you can see here is that that mouse on the right is kind of hedging around that white circle, so he has more anxiety, while the one on the left goes right over that white circle to eat that pellet, less anxiety. So what we found in looking at both our developmental and our young adult models was the same, that developmental SIRT deletion from the gut epithelium was anti-anxiety, both in the open field and the novelty suppressed feeding tests. Similarly, that ablation in early adulthood was also anxiolytic in those same tests. We then did a battery of tests to look at depression. What you can see here is the tail suspension test. The greater amount of time that a mouse spends immobile implies a greater amount of behavioral despair or depression. These mice had less of that, suggesting that SIRT deletion from the gut epithelium was also antidepressive. So we then went to look and see how gut epithelial serotonin may modulate mood. We did not find hormonal implications. Spinal seems to be less effective. The major route that we found was in afferent vagal signaling. Christoph talked about the CCK Saporin method, where you can block out afferent vagal signaling. And we did that, and we had an ablation of the anti-anxiety effects, both in the elevated plus maze as well as the novelty suppressed feeding test. So what about central nervous system development and cognition? So we looked at it in our animal model where SIRT was knocked out of the gut epithelium in development. And just to remind you, systemic SSRI exposure in mice, and to some degree in humans, has been associated with alterations in central nervous system development and cognitive issues. So here I'm showing you where we focused on serotonergic neuron density in central nervous system regions associated with mood and cognition, where there are changes seen in systemic SSRI exposure, but when we ablate it only to the gut epithelium, there are no changes in the dorsal or ventral hippocampus or the medial prefrontal cortex. Similarly, cognition was not affected in these mice in the Morris water maze, nor in fear extinction. So to give you a summary of what I've shown you so far, in mouse and or human studies, what systemic SSRI exposure can lead to include abnormal central nervous system development or plastic changes, cognitive issues, abnormal enteric nervous system development, anxiety and or depression, dysmotility, and disorders of gut-brain interaction. And what we found was that when you delete SIRT selectively from the gut epithelium, the effects are anti-anxiety, antidepressive. There were no adverse effects on central nervous system serotonergic development or plasticity, nor cognition. And what I didn't show for time is that there were also no differences in gastrointestinal motility or enteric nervous system anatomy. But I've talked a lot about this link between systemic SSRIs and disorders of gut-brain interaction, where GI pain is a major feature. So we next evaluated that through something called the visceromotor response assay, where we place a balloon in the rectum of mice with a barostat and pressure transducer. So as we expand that balloon, we can measure abdominal wall contractions as a proxy for abdominal pain. So we did this in our animal model where we ablated SERT from the gut epithelium in young adulthood, and we saw less pain both in males and females, suggesting that targeted SERT blockade in the intestinal epithelium in young adulthood decreases pain in males and females. So in conclusion for this part, mood disorders and DGBIs are common debilitating diseases that often co-occur. Current treatments are inadequate, and systemic SSRIs, although they're first-line therapy, are fraught with all of the issues I've talked about. So more targeted therapies are needed. An increase in gut epithelial serotonin by SERT ablation we've shown is anxiolytic, antidepressive, does not induce other systemic SSRI-associated adverse effects, and that gut epithelial SERT ablation during young adulthood is anti-pain. There's a lot I'm not talking about today, including important sex differences and the modulation of gut epithelial serotonin. I know there's a number of people here, and Elaine has certainly worked on the microbiome and serotonin, so there's things I'm not talking about which absolutely play a role. And there's a gut epithelial targeted SERT antagonist is currently being trialed. And again, I want to say this is not a call for pregnant women not to use SSRIs. And just to reinforce that point, we did a population-based study looking at over 12,000 children and looked at pre and or postpartum depression, and we specifically focused on women who did not take SSRIs. And what we found was that there was a significant risk of DGBI development in other DGBIs, functional nausea and vomiting, abdominal pain, and infant colic. Some of the other directions we're going in, and this is a disclosure as well, that we've developed novel drugs and drug delivery systems to target the concepts that I've talked about. In terms of our expansion of Get Gas, I've talked about the first 24 months, but we've been able to relate some of these just recently to both cognition and social emotional behaviors, as well as data suggesting that there are microbiome differences amongst different SSRIs. And then I'll end with the last part that we're exploring is, do different types of early life stressors induce more severe and or different DGBI symptoms? We've looked at over 40,000 children in the Adolescent Brain and Cognitive Development, or ABCD study. And what this does is, although it doesn't give us comprehensive a view of GI symptoms, it gives a much more specific look at which specific types of early life stressors might affect GI symptoms. And what you can see, and this is a very preliminary look, is that there may be a decreased odds ratio with some adverse childhood experiences versus others. And the reason we're starting to do this is that we can then go back and look at mechanism in our animal studies, if we can model what these exposures are, to suggest that different exposures may lead to different DGBIs. So at the end, I just want to thank, I've highlighted Lynn Hung and Sarah Najar, who really spearheaded a lot of these studies, as well as the rest of my lab team. The Ansorge lab at Columbia really helped us a lot at the beginning with the brain studies. We have great collaborators for the SSRI population-based study and Get Gas. And of course, I wouldn't get anything done without these people, nor my research support. Just to tell you also, as Julia mentioned, I direct a pain research center at NYU. Happy to answer questions about that offline. We have a lot of resources, including core facilities that we've established. And if you want to know more, you can follow us. Thank you.
Thank you so much. Are there any questions?
Interesting talk. I had a question following up on your pain data. It's kind of counterintuitive because SERTs would increase the concentration of serotonin. So could you comment on why you saw less pain?
Sure. I mean, we're looking into it. I think that you're right, because David Julius's paper, which looked at enterochromaffin cell activation, showed increased pain and increased afferent vagal signaling. I think there's a there's a couple of reasons why. I think one, we've seen in a variety of studies that when you antagonize SERT to increase serotonin versus stimulate enterochromaffin cells, different signaling pathways are activated. We haven't published fully on that, but we've started to in this initial paper. So, you know, so we do think that there is a different signaling pathway that it's going, or different mediators are released when SERT is antagonized versus when EC cells are directly stimulated. We're starting to look at that more carefully now and looking at what those modulators are. The other thing is that we think that there's a good degree of receptor desensitization and intracellular trafficking of receptors, and we're looking at that as well. And I'm not sure why that doesn't occur in EC cell, because our EC cell data matches what David Julius's data showed, but there's a different mechanism of desensitization that's occurring that we're now looking into and actually targeting as well. Looks like I answered everyone. Oh, okay.
Thank you for the talk. Sure. I was struck while I was listening to the description of the mouse models that followed the hypothesis that there were off-target effects of SSRIs, that those mouse models might be an opportunity to identify those by treating the knockout animals with SSRIs. Is that something you're looking into?
Absolutely. We're doing those experiments right now, but that's an important set of experiments.
Hi, thank you very much for the really great talk. My name is Amira Latif Hernandez. I'm very fascinated about your results, and I'm very curious to know if there is any other approaches, like, for example, using neuromodulators that are targeted directly in the epithelium, for example, of the gut to reduce inflammation in this DGBI, for example, or since these disorders are very associated to neuroinflammatory pathways, like any sort of treatment like steroids to reduce inflammation, would that be another approach in combination with the SSRI to reduce the symptoms?
Sure. Let me put those out. I think what I would say is, yes, we have developed drug delivery systems, and we're now developing a drug that's targeted there. And those are being trialed right now. And this is curious for us too. Inflammation has been shown to potentially be exacerbated by epithelial serotonin, which we showed ourselves. And so again, I'm not sure what the balance is there between inflammation, whether you just need a pre-existing condition and that serotonin may increase that. DGBIs are a little harder because there's only a subset of patients that actually have at least detected inflammation. And SSRIs have not been looked at in terms of a post-infectious IBS, which is more of an inflammatory phenotype versus just a chronic pain that did not come from infection. But we are starting to look at that and our drug delivery systems in these different models to see exactly that, if it's inflammation or if there's more of just a long-term visceral pain that may be more centrally mediated.
Hi, my name is Lean. Really great talk. I was curious about get gas and about checking like the stool of the babies. I was wondering if you controlled for women giving birth through C-section or vaginal birth, and how you controlled for microbiome differences that might have been caused by if the women were giving birth through vaginal births.
No, absolutely. We are looking at that right now. It's why I haven't put up a lot of the data that we have, because we're now looking at all the covariates that can affect it. There absolutely can be. Overwhelmingly, this population's in Canada, and so there's many less C-sections in Canada, and so the vast majority of our patients had vaginal births. So it may be hard to directly compare. And we also found C-sections happening more in the women who took SSRIs, which make it a little more complicated as well. But we are absolutely looking at that, and it's something important to consider.
So I have a question here. So very interesting talk. So I just want to know, do you know how much serotonin concentration can change after the SSRI? Because in the gut, you already said, it's a very high baseline, right? 90% of the serotonin is in there. I assume the increase will be small.
So it's right, it is, but for the reason of the mechanism. So platelets have SERT. And if SSRIs are systemically absorbed, they block SERT on the platelets. And so the platelets can't take in serotonin. The vast majority of serotonin measured is coming from the platelets. Free serotonin makes up a very small amount. It can still have effects, but it makes up a very small amount. So it's very hard to measure serotonin under SSRI exposure, but it tends to be low specifically for that reason. I should say too, we did look, we looked at blood levels. We also did mass spec and HPLC to look at gut epithelium and gut enteric nervous system and did not see differences, but SERT is like a sponge. It takes up serotonin so quickly and inactivates it that it can be really hard to compare when you're using SSRI versus not. Hopefully the epithelial studies will, the targeted drug delivery systems will be able to answer more of that for us.